like to welcome you to When the 12 Steps Aren't Enough, the Use of Exposure with Response Prevention, or ERP, as we fondly call it, in the treatment of substance use disorders. My name is Dr. Andrea Kulberg. I am the clinical director here at La Ventana in beautiful Santa Barbara, California, and I'm so glad that I could speak to you today about this exciting topic. First, we're going to go over some anxiety and addiction basics. Anxiety disorders occur in 18 to 28% of the US general population during any 12-month period. And among those with anxiety disorders, there's a 33 to 45% 12-month prevalence rate for the comorbid disorders of substance use and anxiety. And those with GAD have a pretty high prevalence, as you can see there, of comorbid alcohol abuse and other types of substance dependence. So we're treating a lot of anxiety when we are in our treatment centers treating substance abuse. So is it the chicken or the egg? Does the anxiety cause the addiction? Is it self-medication, or does the addiction cause anxiety? The answer is it can be both. The use of alcohol or drugs can cause neurological changes in the brain that may trigger or intensify anxiety. And at the same time, anxiety can be a motivating factor in substance abuse. So I'm nauseous, I don't feel good, I need my Ativan. So let's talk about the anxiety continuum and tolerance for uncertainty. What are we treating here? We've got the anxiety spectrum from simple phobias, right? 1 in 10 people has a simple phobia, generalized anxiety disorder, going down the continuum to panic disorder and social phobia, PTSD, right? You can acquire an anxiety disorder from traumatic events that happen to you. And the most severe anxiety disorders we have, OCD and eating disorders like anorexia and bulimia. We used to sit around in eating disorder treatment. I'm an eating disorder and anxiety expert, not a substance use disorder expert. We used to sit around and just try to decide in our eating disorder team meetings, what does this person have in terms of an anxiety disorder in addition to their eating disorder? But over the last 20 years, as I've treated more and more people with eating disorders and anxiety, it's become clear that the eating disorder is the anxiety disorder. And I was just speaking at the International Association of Eating Disorder Professionals conference in Florida on the fact that obsessive compulsive disorder and disorders like anorexia and bulimia have so much crossover now that they're diagnostically indistinguishable. And so we consider them to be, in the last 5 to 10 years of the research, different phases of the same disorder. But of course, that's another webinar for another time. So the important thing to remember about the anxiety continuum is that the further down the continuum you go, the greater the genetic load for anxiety, okay? So anxiety runs in families. We're born with a greater genetic load or a lesser genetic load. And when we make it further and further down the continuum in terms of our genetic load or events that happen to us that make our anxiety worse, then we have greater and greater difficulty with living with uncertainty and overestimating risk in all situations. Okay, so the more the person has difficulty living with uncertainty and overestimates risk, the more they engage in the safety behaviors that grow anxiety, which are avoidance, reassurance seeking, and compulsions or rituals. If you don't remember anything else from this webinar today, please remember that what anxiety lives on is avoidance, reassurance seeking, and compulsions. Okay, we call those collectively safety behaviors in the anxiety treatment world, in exposure therapy. So now you might be asking, well, I'm a substance use disorder expert. You might be asking, well, which is addiction? Is it avoidance, reassurance seeking, or compulsion? And the fact is, it's none of the above. Addiction is not a compulsion, okay? So we want to get our terminology straight. When we're talking about anxiety and substance use does not equal compulsive behavior. When we're just trying to define our terms, addictions are impulse control disorders. They are egosyntonic. They are positively reinforced, and compulsions are done in an effort to neutralize obsessions. Compulsions or rituals are ego-dystonic, and they are negatively reinforced. Okay, so when we are using a substance, it's activating the pleasure or reward centers of the brain. The drug or substance or a behavior like gambling is a pleasurable experience that we want to feel instead of feeling the body sensations of anxiety if we're someone that has anxiety, right? We're talking about comorbid situations, right? Substance use disorder and that predisposal to higher levels of anxiety. So in addition to seeking out a pleasurable experience, people with addictions are also doing those three behaviors, all or some of those three behaviors that worsen anxiety: avoidance, reassurance seeking, and compulsions. Again, I'm going to say that over and over. So that those behaviors that worsen the anxiety, the avoidance behavior, the reassurance seeking from those they love, from the internet, etc., about things they're worried about, and the compulsions are why they keep thinking they still need their pleasurable substance experience, okay? They believe the lie that the anxiety is dangerous, it will drive them crazy, it will never end. So they decide that a substance is the only way that they can cope, right? I just need a break from this anxiety. I've got to lower my body sensations of anxiety, okay? So the definition of an obsession is a recurrent or persistent thought or urge or image that is intrusive and unwanted and marked in most people by anxiety or distress, okay? So I want cocaine is not an obsession. A compulsion is something you do to neutralize the obsession. It's a repetitive behavior, hand washing, ordering, checking, or a mental act like praying or counting or repeating words or phrases silently that a person feels they have to do in response to an obsession or according to rigid rules. So the compulsion is aimed at reducing anxiety or preventing a feared outcome. All right, so those are the definitions of obsessions, compulsions, and then substance use. So what is it that we're treating with anxiety? Anxiety is anticipation of future threat. It's not the same thing as fear. Fear is about real and present dangers. So the fight or flight response with fear is about I'm hiking, I see a bear, and I'm overcome with fear because there is real and present danger. And I have this fight or flight response. Okay? Anxiety is anticipation of future threat. It's anticipation of what might go wrong. Okay? It's a normal state. Anxiety is a perfectly normal state, but you can have too much of a good thing. So another thing to differentiate anxiety from, besides differentiating it from fear, is stress. Stress are real events that might stack up. So I went through a divorce, someone in my family died, and I lost my job. And now I'm clinically depressed or something, right? So stress buildup is not the same thing as anxiety. Of course, anxiety has a field day with stress buildup, but anxiety all by itself, we have zero research to suggest that it's dangerous or can be harmful to your health. There is some research that can suggest that stress can be harmful to your health, but there are big moderator variables with that. Kelly McGonigal does research on this. You can watch her one of her fun TED Talks on it or something if you want to just get a little information on the difference between what makes stress harmful to your health or not. And what she finds when she studies thousands and thousands of subjects is that stress makes a difference to your health if you believe it will be harmful to your health. So she looks at thousands of people and their stressors and sees how long it takes for them to die, basically. And what it turns out, the major moderator variable is this going to be harmful to my health, this level of stress? And that's the one of the major determining factors of whether stress is going to be, in fact, harmful. So anxiety is not fear, it's not stress, it's a normal state, everybody has it, it's temporary and harmless. And 3 lies go with it. If you look in the DSM-5 and the definition of panic, it'll list all the body sensations of anxiety, and then these 3 lies that go with the anxiety. That it's gonna kill me, right? I'm afraid of dying from this. I'm afraid I'm gonna lose control or lose my mind. I'm gonna snap and do something rash. And maybe it's never gonna end. It's never gonna go down, right? And of course, we know that that's a lie, because if you think about the thing you've been most anxious about in your life, the times when you've had the highest levels of anxiety, it always had a beginning, a peak, and a downward slope. It always goes down. It's always temporary and harmless. But in the moment, it feels very strong. Feels like you have to do something, okay? All right, so what are the normal body sensations of anxiety? Why am I teaching you these? Because I want you to tell all this stuff to your patients. Everything I'm saying today, you're gonna teach your patients as a part of exposure with response prevention therapy. So the #1 body sensation of anxiety, nausea, stomach upset, diarrhea. 80% of the time, someone shows up at their primary care physician, they've got gastrointestinal complaints, it's anxiety. Along with that, we'll often go a racing heart, sweaty, hot, cold sensations, difficulty breathing or like a choking sensation, trembling or shaking, tearfulness, numbness or tingling, kind of an out-of-body derealization or depersonalization experience. And then, of course, we have all those occurring together at a high level, or several of those in a cluster occurring together, heightened body sensations, we call it panic. And the definition of panic is the catastrophic interpretation of these normal body sensations. So when a person is having the normal body sensations of anxiety and they're believing the 3 lies we talked about, that this is going to be dangerous to my health, it's going to drive me crazy, it's never going to end, they ramp it up with that catastrophic interpretation to panic levels, okay? Still never dangerous. People go to emergency rooms every day, right, with panic attacks, and they take your vitals, they say, yep, your heart rate was elevated, because the person says, I'm having a heart attack. Yep, your heart rate was elevated. Yep, your blood pressure is a little up, but never out of the normal range, because no amount of anxiety can cause a person a stroke, can cause a person to go crazy. Anxiety is temporary and harmless. You can't repeat that enough to your patients, right? Nobody's probably ever told them that before, okay? So the way I like to draw the anxiety spectrum, I didn't get this from a book, this is my own creation, is I like to divide it into 2 ends of a continuum with average levels of anxiety in the middle. And then I talk about the people on the left of your screen there with lower than average anxiety who never come to see us. And then the people on the right who are on the anxiety disorder spectrum, because the anxiety is at levels that cause it to interfere with their life, right? That's when we call it a disorder, is it causes a certain amount of distress and it's interfering with their life a certain amount, right? So we've got simple phobia, generalized anxiety, social phobia, agoraphobia, and panic disorder. We've got obsessions and compulsions, sort of like OCD light, that takes up less than an hour of your day. And then the most severe end of the continuum, where obsessions and compulsions are taking up more than an hour of the person's day. And they are also at very high risk for an eating disorder, such as anorexia, bulimia, or avoidant restrictive food intake disorder, right? Okay, so that's my anxiety continuum. So how are we going to treat anxiety, right? Anxiety is the most common thing that all therapists treat. So we ought to be experts at the #1 treatment. Exposure with response or ritual prevention, those 2 terms are interchangeable in the research literature, is the #1 treatment for the anxiety spectrum that I was just talking about, okay? And the manual on exposure with response prevention has been written by Jonathan Abramowitz. It's called Exposure Therapy for Anxiety, Principles and Practice. And once you learn exposure therapy, really it transforms your whole therapy practice, okay? Because it's our most powerful, empirically validated tool for the entire anxiety spectrum. The research on ERP for all anxiety disorders gives us the largest effect sizes in our field for any type of treatment. ERP was developed out of CBT, so it is a kind of CBT. And the reason why we don't use CBT alone for anxiety disorders is because when we are weighing the evidence for a certain thought, right, we all teach our patients CBT, and maybe they're having the thought today, I am worthless, and so we look at that thought and we say, okay, really, are you totally worthless? Is there nothing at all of value about you? Is it really black or white like that? Isn't that what we call the irrational thought, the cognitive distortion? Black and white thinking? Why don't we come up with a more reasonable thought? And then we say, yeah, there's not much evidence that you're completely worthless. There is evidence that you have some value in this life. So let's restructure that thought and think of a more rational thought, okay? The reason why we can't use that alone for anxiety disorders is because ultimately it functions as reassurance. And did I mention that anxiety lives on avoidance, reassurance seeking, and compulsions or rituals? So therapists are very good at providing reassurance, right? They're very good at saying, that's not likely to happen, or let's not think like that, or what's the evidence that that could really occur? And ultimately, we can't know if that thing is going to really occur or not. And so in ERP, we're going past teaching about black and white thinking and other cognitive distortions. And we are agreeing with thoughts that the feared outcome might really occur, because no one can have 100% certainty that a feared outcome won't occur. But that is what anxiety wants. Above all else, anxiety wants 100% certainty. And so when therapists are getting locked in circles in their offices with their patients, they don't realize it, but they're actually making anxiety worse when they're providing reassurance to their patients that a feared outcome won't happen, or getting mired in weighing the evidence over and over, right? If someone thinks that they have dangerous germs on their hands and you're telling them, why do you need to wash when you've already washed and you already know there aren't any germs on there? Well, no one can have that, really. Why would we say that? There's always going to be germs. Germs are everywhere. We breathe them. They're in the air. We touch them on every object that we touch, right? I read the other day that a cell phone is as dirty as a public toilet, but everybody is holding that up to their mouth all day. And even when the surgeon scrubs their hands before they go into the surgical suite, there's still bacteria. That's why people still get sick from surgical intervention, right? So we're not going to reassure patients that a bad outcome won't happen. We're going to say, maybe it will, maybe it won't. We have to live and see how it turns out, okay? All right, so what does ERP consist of? The title is Exposure with Ritual or Response Prevention. So the first part is exposure. We're inviting anxiety on purpose during exposures by entering situations or inviting unwanted thoughts or images, right? Remember, obsessions are recurrent and persistent thoughts, images, or urges that are intrusive and unwanted, okay, and produce a lot of distress. So we're going to either go into situations that produce anxiety that we've been avoiding, or we're going to invite thoughts that we've been trying to stop or avoid or distract from, okay? We always want to encourage our patient to allow their thoughts to be present. You never want to try and stop thoughts, okay? That's a debunked non-scientific method that was developed 30, 40 years ago and debunked in the literature very quickly, called thought stopping, where people were teaching patients to try and stop their thoughts, and that would be like trying to stop the rain, right? No one can do that. The mind is a thought-producing machine. It's a thought-producing conveyor belt, and we're never going to try and stop thoughts, because what we've learned in the research is that any efforts to stop or distract from thoughts increase their frequency and intensity. And so in ERP, we say, if you want to think about anything less, you're going to think about it more. So in exposure, we're entering situations on purpose and inviting thoughts on purpose that we've previously tried to stop or distract ourselves from or decrease, okay? So there are live exposures where we are going to go into a social situation or another type of situation that produces anxiety. And this includes interoceptive exposures. So sometimes we're just inviting the body sensations of anxiety in a situation by trying to produce hyperventilation, heart racing, dizziness, sweating, nausea, okay, by breathing through a straw, breathing into a paper bag, spinning, doing all kinds of interoceptive exposures. So those are all live exposures. And then we have imaginal exposures, which is the use of exposure scripts, where we actually write down thoughts to invite these unwanted thoughts that are causing us the most distress, and then we repeat the thoughts over and over and over, either recording them to play them back over and over, or reading the written script and inviting the anxiety over that, okay? And then reminder on exposures, if I didn't say it already, that exposures are always graduated and repeated. So we are increasing the difficulty of exposures, making lists of them and increasing their difficulty over time. And I'll show you how that's done with some examples here in a moment. Second part of ERP, the response prevention, is we are preventing the usual response to the anxiety of the safety behaviors that I've mentioned several times, right? Anxiety lives on avoidance, reassurance seeking, and compulsions. So we're preventing that. That's the response prevention part of ERP. All right, so now you're saying, well, great, well, what do I do with the patient in the session? Well, the first thing you're gonna do is teach them everything I've taught you so far. You're gonna tell them about the anxiety continuum. Never do ERP without a whiteboard, right? You're constantly writing on the whiteboard. You're constantly teaching them about the anxiety cycle, the body sensations of anxiety that they think are dangerous, right? Reminding them that their anxiety is only temporary and harmless. You're going to design your exposures, both live and imaginal, that I just referred to in earlier slides. You're going to create your exposure hierarchies, have the patient complete their exposures, and then eventually the patient becomes their own ERP therapist and fires you. They might need some refresher sessions later in their treatment, but later in their life, but they can fire you temporarily because they're going to become their own ERP expert, okay? And hopefully the outcome of this with substance use disorders is, and I've helped hundreds of people in my 20 years stop using substances because they have become the masters of their own anxiety, right? Because you only have two choices in life when you have higher levels of anxiety. You're going to be a slave to avoidance, reassurance seeking, and compulsions all day, or you're going to be the master and you're going to learn that my anxiety is not dangerous. I can live and embrace uncertainty in all these areas that I've been practicing my ERP and see how things turn out, all right? Okay, so anxiety, as I said before, lives on three things that people do in a fruitless effort to be safe or sure about something. So when you're teaching your patients about what anxiety lives on, you're going to tell them no point in trying to be safe or sure in life, right? Because no one can have that. We can do all kinds of avoidance, reassurance seeking, or compulsions to try to eliminate the chance that there'll be danger, which no one can have. There are dangers all around us. Or to try and be 100% sure about something, which no one can have, right? We don't even know if the sun's going to come up tomorrow, right? It's supposed to go supernova at some point. So there is no certainty about anything in life, right? So one of my patients said to me the other day, she has osteoporosis from her severe anorexia from decades of starving herself. And she said, you know, I just don't know if I can go back to my activities because what if I have another fracture? She's had some fractures due to her osteoporosis when she was underweight for so long. But now she's almost to her target weight. She's going to physical therapy and occupational therapy. Her body is getting very strong. Her therapists have told her she can go back to her normal activities except certain types of weight-bearing exercise. And she's just afraid to do that. And so we were talking about how she could break an ankle stepping off a curb like my sister did, you know, once. And there's no way to prevent that. There are dangers all around us, right? I said, I can get in a car accident on the way home from work today. This might be our last conversation. You could have an aneurysm in your sleep. There's no way to know, right? We're going to live and see how it turns out. We're going to embrace that uncertainty. So you're going to talk to your patients about how the anxiety cycle works. You're going to let them know that having higher levels of anxiety is like having a monster that lives in your brain that brings up the what if thoughts. What if I'm overweight? What if I didn't make the right decision about that relationship? What if I get sick? And then it sends high levels of anxiety. All the body sensations, nausea, difficulty breathing, stomach upset, hot, cold sensations. And then it demands that you do something. Guess what the three things are that the anxiety monster wants you to do? It wants you to avoid a situation or a thought. It wants you to, or an image. It wants you to seek reassurance from someone that you love or the internet. Or it wants you to do some kind of ritual. It wants you to check something, count something, repeat something, recite something, etc. Okay? Problem is, because the anxiety lives on those things, when you do it, it lowers your anxiety for a moment or for an hour or for a day. And then you fed the monster in the long run. So you lowered your anxiety for a moment, but because that's what anxiety lives on, you fed the monster. And guess what? Next hour or next day, the monster is bigger and louder. And you have even more thoughts. What if I'm sick? What if something bad happens to someone I love? What if I'm not healthy enough? What if I'm didn't make the right decision about X? And even higher levels of anxiety, and then even stronger demand to avoid some more, seek reassurance, do compulsions. I like to tell the story of treating a man who was locked in his house for 6 months before I saw him, and he was having all kinds of panic. And so I started to see him on live video, taught him all this stuff about anxiety and started his ERP, and asked him during our sessions how he got this way. And of course, he told me the story of how he was having severe anxiety at work about something, started to have panic attacks while driving. Then he started to ride with a friend and had panic attacks because he avoided driving. Fed the monster, had now had panic attacks while riding in the car with a friend. So he takes a leave of absence from work, and then he starts to have more avoidance, so higher levels of anxiety. Now he's having panic attacks while he's driving and going to the store, just within his own community. Then starts to avoid going to the store because his mom is going to accommodate him by bringing him groceries. Then he stays at home, doesn't leave the house, and is lived into a very tiny box, right? That's what the anxiety monster does. And so the only way out of the tiny box is to stop the thing on the right, which is doing something in response to the anxiety. We have to teach our patients that they're not going to alter their behavior in any way in response to the anxiety. They're not going to lay down. They're not going to cancel an engagement. They're not going to ask someone if they're going to be safe, or going to be okay, or going to be sure. They are not going to do a ritual to try and prevent the feared outcome. They are going to let the anxiety be there because it's going to be temporary and harmless, right? They're going to wait till it peaks, go on with what they were going to do anyway while it peaks and until they're on the downward slope. Because going on with what you were going to do anyway sends the message to the body and mind that you are not in danger. When you lay down, breathe, do your diaphragmatic breathing, take a detour, avoid a situation, leave a situation, etc., you are telling the body and mind, I couldn't handle those body sensations. It wasn't going to work out for me. I can't handle my anxiety. It's dangerous. It's going to drive me crazy. It's never going to end. And you're just driving it up that whole time, okay? Because anything we persist in the body and mind, anything we resist in the body and mind persists, okay? So we're also going to teach the patient, as I said, about their body sensations. You're going to write down their body sensations. They're going to memorize their body sensations so that they know how to identify those. You're going to teach them those 3 lies, that it's not true that anxiety is dangerous. It's not true that it can drive me crazy, and it never lasts forever. It always has a beginning, a peak, and a downward slope. Usually lasts 5 to 15 minutes for a panic attack, for example. And so I'm going to keep drilling into them. Yep, it's temporary and harmless. You'll be the first person to tell them, I guarantee you, that their anxiety can't hurt them. Their physician hasn't said that. Their previous 3 therapists haven't said that. You know why? Because those people didn't know. They weren't trained properly. Unless they worked in an emergency room and saw hundreds of people with panic attacks, they weren't trained that anxiety is never dangerous, okay? So draw the bell curve frequently in the air on your whiteboard about how it's gonna have a beginning, a peak, and a downward slope, right? And that the fastest way to the downward slope is to let the anxiety wash over you like a wave, and in fact, to invite it to intensify. Okay, if they want the anxiety to go down quicker, they're going to demand that the anxiety get worse. If I'm going to have a heart attack or faint right now, let's just do it and get it over with. Okay, we're just going to invite the anxiety to wash over us like the wave. Okay, any resisting, any bracing against it? Oh, Sally, you look like you might be bracing against the anxiety even right now while we're talking here. Okay, that's going to drive it up. Whereas if you let it come, if you invite it to get worse and to peak, you'll be on the downward slope more quickly, right? Oh, but I don't feel good. Oh, I can't eat the rest of this. Oh, maybe I should avoid eating that in the future. Let's not try and figure out what caused this, because that's not going to help anybody. Let's let it peak while we do what we were going to do anyway and see how it turns out, okay? I need to leave group, someone said to me yesterday at the clinic. I need to leave group, I don't feel good. And I said, why don't we see if it's anxiety, if it peaks and goes down while we go on with what we were going to do in this group, right? We were in a CBT group. Let's just talk about our cognitive distortions, see how it turns out, see if you still feel that way in 10 or 15 minutes, okay? If you're going to use breathing with your patients, you're going to help them move toward anxiety, not away from it. And they're not going to wait to go on with what they were going to do anyway. They're going to keep doing what they were doing while they breathe toward their anxiety, inviting it to peak as quickly as possible. Another metaphor I like to use with my patients is the conveyor belt or the movie theater, okay? So when you're teaching them that their thoughts are never going to stop, so never try to distract from them or practice any thought stopping, You're going to tell them that the thoughts and the body sensations of anxiety are not the problem. Your body is a conveyor belt. The mind is a conveyor belt of thoughts and emotions. None of those are the problem. It's what you do with them that's the problem. It's your response to the thoughts that's the problem. No one with anxiety, even with OCD, has any unique thoughts, okay? Thoughts are common to all people, okay? People have bizarre thoughts, disgusting thoughts, aberrant thoughts, happy thoughts, sad thoughts, vulgar thoughts. They're common to all people. Emotions common to all people. It's the response that's the problem. When you respond with avoidance, reassurance seeking, and compulsions, that's when we jack up our anxiety. Okay, so we're going to let the thoughts and the emotions be there, and we're going to respond by allowing them to flow through us while we do what we were going to do anyway. Another analogy I like to use is palm tree coping. So we're going to cope with your anxiety the way the palm tree copes with the wind, flexibly, right? We're not going to use the oak tree strategy, which is to become rigid and upright. And what happens, the oak tree in the wind falls right over, right? Shallow roots, palm tree, excellent flexibility, says bring it, right? You can see it on the side in the hurricane, bent over with its fronds extended. It's going to let the anxiety be there, let the wind come, bring it. That's what we're telling the anxiety to do, peak, all right? So how do we make our exposure hierarchies? After we teach the patient all about the anxiety cycle, how they are making their anxiety worse with avoidance, reassurance seeking, and compulsions, how are we going to do our exposure hierarchies, all right? So for live exposures, we're going to make lists of feared social situations. If the person is coming to see you for social phobia, we're going to make lists of feared foods and stores, items in stores. If they are coming to you for an eating disorder, if they are having contamination fears, we're going to make a list of feared objects or places or contaminated people even, depending on what the OCD is focused on in that case. We're going to make a hierarchy of feared body sensations and do our interoceptive exposures if the person is afraid of their own body sensations of anxiety. And then we are also going to make hierarchies to reduce compulsive counting, checking, repeating till they are extinguished, okay? And then also with imaginal exposures, right? If someone comes to see us for some distressing thoughts that they're complaining about, and they're not doing any rituals or avoidance behaviors, they are just having a lot of distressing thoughts, then we're going to create imaginal exposures by writing scripts that they repeat over and over and over to invite the disturbing thoughts or images and habituate to those, okay? Because the more we think about a thing that we've been trying to not think about, the lower our anxiety goes, right? The more we try to stop thinking about it, the higher our anxiety goes, okay? And the more frequent and intense the thoughts are, right? We talked about that earlier. Okay? And so we're going to reduce mental compulsions by the script writing and inviting disturbing images, okay? So what are the exact exposure procedures? Again, I said earlier that exposure should be graduated and repeated. We're not doing implosion, right? We're not going to overwhelm the patient. We're also not going to just do an exposure once or twice because that won't be sufficient. We didn't get this way, locked in our house or whatever, doing compulsions or avoidance behaviors because of one behavior. It was a pattern of avoidance, right? So we need to do exposures over and over and over every day in increasing level of difficulty and not go back to our lower level avoidance, reassurance seeking, or compulsion behaviors, okay? Until all the behaviors, the safety behaviors are extinguished. In treatment, we use a SUD scale, subjective units of distress scale. I use 1 to 10. Some people use 1 to 100. But this is how we're going to rate the hierarchy, the behaviors on the hierarchy that we're going to engage in, okay? And then we're going to generate as many feared situations as we can and thoughts as we can, and we're going to have the patient rate them using the SAD scale. And I'll show you some hierarchies here in a minute that have ratings on them. We're going to start with the lowest items on our live exposure hierarchy and have the patient do these until they are easy. Then they're going to move on to higher and higher items, okay? And we're going to have them continue to repeat the lower items daily so that they don't go back to their old behaviors. When we are using imaginal exposures or scripts, we have the person read the script over and over daily in a single sitting until the patient's anxiety peaks and comes down by half the peak level, okay? So the script that we write of all their feared thoughts on a given topic, the obsessional topic, that should be boring within a week or less, okay? And so it's going to seem ridiculous to them over time. So here's a sample live exposure hierarchy for OCD. This was a patient who was locked in their house doing compulsions because they could not complete their morning routine if they had a thought of death or cancer in their head. And so it could be any possible link 2 or 3 times removed to death or cancer, and then they'd have to repeat the activity. So this patient was a 40-year-old male who could not get through getting out of bed, going to the bathroom, dressing and undressing, getting up and down from the toilet. Each step of that, he had to try and rid his mind of thoughts about death or cancer, or he couldn't complete the next step in the activity. So you can imagine he couldn't get out of his house in the morning. So after we did the initial teaching about the anxiety cycle and ERP concepts, the patient was able to, at least in the session, talk a lot about death or cancer thoughts. And so I would have him recite the wrong thoughts about death or cancer over and over. And those only caused, over time, an anxiety level of 1 to 2. So that's where we started our exposure hierarchy after the first 3 or 4 sessions. And then we went up from there. We made a list of all these things that are on this exposure list, and then he rated them from 1s to 10s, okay? So the lowest things on the hierarchy are, saying the wrong thoughts, writing down the wrong thoughts, saying the wrong thoughts when he's doing various things in the house, being in the bathroom for shorter and shorter amounts of time, and saying the wrong thoughts aloud. We're doing all these things, all these tasks are being done while you're agreeing with the wrong thoughts, okay? So he would mark off the 1s, 2s, and 3s for the first week and do them over and over and over until they were easy. Maybe it's only going to be the first 3 or 4 days between now and the next appointment, but he's going to do those over and over and over. So he's going to write down things about death or cancer. He's going to look up things about death or cancer, look at the words as often as possible, say aloud the wrong thoughts over and over, and do that for several days. And when those are easier, then he's going to do 4s and 5s while he keeps doing the 1s through 1s and 2s and 3s, okay? Then, and so forth, and working up the hierarchy, okay? Until you do the thing that you are most terrified to do on a regular basis, okay? Social exposure hierarchy. So this is a patient with social phobia. This is a list of social exposures that were very hard for this patient to do. And she was to complete them all while agreeing with thoughts about the feared outcomes. So she would say hello to a stranger at the bottom of the hierarchy there and make eye contact with strangers while agreeing with thoughts that they don't like me, I'm an imposition to them, I'm a burden, maybe they thought I was dressed weird, maybe they thought I didn't look right. This feeling of exposure that I have when I'm out in society might kill me, it might make me go crazy, who knows, whatever her anxiety is telling her might happen. And then she's gonna do that as well as asking the strangers for the time or directions, or asking where a bathroom is in a restaurant. She's gonna do those things over and over and over, every single day, multiple times a day, until they're easier. Then she's going to go on to things like calling a store to see if they have a random product while agreeing with thoughts that she's inconveniencing the the store clerk, that maybe there's a line there and that she's disrupting what they're doing, that the stranger that you asked to reach something for you in the store is upset with you or angry with you or thinks you're rude or an imposition, etc. Going up to higher things on the hierarchy, like visiting a place where you had a previous panic attack and inviting panic. This patient also had to, on a different exposure hierarchy, go further and further away from home. She was 22 years old and had never spent the night away from home due to her severe social phobia. So her next exposure list was to take trips further and further away from her house till she drove to a place 3 hours away and took herself on a weekend trip at the top of that exposure list. So this was our first social exposure hierarchy before we went to a more complicated one. But things for her like saying no to a friend, that's not convenient for me, that's not going to work out for me, or saying no to a relative while agreeing with thoughts that they might be hurt, that they might do something catastrophic, that they might feel slighted by her or angry at her, etc. Were very difficult for this patient. Also, here's an example of the imaginal exposures. Here's a script for someone with anorexia. I sat down with a patient not too long ago, and she was talking about all her fears of getting to her target weight, and that she had been in treatment for 5 years and had never been in her target weight for any length of time, and never even gotten to her target weight, I believe. And so I said, well, what's going to happen if you get to your target weight? And it must be something terrible that's going to go on. So I got out my computer, and we used what we call the downward arrow technique. And here's what she said. She said, well, I'm going to lose control. And I said, oh, well, then what will happen? And she said, well, I'll be an outsider. I'll be fat, lazy, unproductive, unsafe, and unable to fit into my clothing. And I said, okay, well, what's the worst that can happen if that occurs? Well, I'll be unnoticed or invisible to others and bored, and I'll be lazy. I'll be unattractive like I used to be before my eating disorder and subject to criticism. Oh, okay, well, what's going to happen if that occurs? Well, I won't be successful in my life because I won't be as efficient and task-driven. Okay, well, how will that look? Well, I won't show enough discipline. I'll go back to not caring about things. She was a college student, so she said, I'm going to fail out of school, whatever. So I wrote down everything she said. She said her eating disorder gives her protection and a state of calm. And it's going to have all this impact on her social relationships, where she won't be able to have satisfying relationships with people. She'll be over-emotional. The anxiety will take over her life. And on, okay? So what she did was, in the session after we made this script, I had her read it to me, which caused her to cry. And then I said, let's read it again. And she cried more. We rated her anxiety. How high is your anxiety while you're reading this? Oh, a 7 or 8. Okay, again. So she read it again. It was always a 7, 8, 7, 8, 7, 8. And then after she read it for about the 10th or 11th time, she realized that she was down to a 6. And then she read it again, realized she was down to a 5. Pretty soon it was 3 or 4. So we went until it was 3 or 4, till it was about half the peak level of 7 or 8. And then we stopped reading after about 15 to 20 reads. I printed out the script for her, told her to use it every day in the same manner, reading it over and over and over again to herself, telling herself that it could come true. There'd be no way to know. There are no guarantees in life, and practice that each day. So after 3 or 4 days, she said, I realize that this is ridiculous, that of course I have no idea what's going to happen if I get to my target weight. And I can't predict, there's no way to know, I'm just going to have to live with that. And I said, yep, that is the place that everybody has to come to in order to recover from anorexia. They have to be willing to say, maybe I'll be fat, maybe my life will be horrible, maybe not, and trust their team to put them at a healthy target weight and live and see how it turns out, okay? And so, of course, we had to revise the script and make it harder as she went through her treatment, because when she got to her target weight, then she had to go out and be in the world and live at that target weight, expecting people to reject her, expecting that she wouldn't be able to find any meaningful relationships, etc., and that she would be so distressed she couldn't go back to class, etc. And of course, we made it through all of that by inviting those thoughts to become more frequent rather than less frequent, because she learned that if you want to think about anything less, you think about it more, and you tell the body and mind thereby that no thoughts are dangerous. Any thought or body sensation is tolerable. My body is made to handle any thought, any intensity of body sensation, and I can go on with my day to let the body and mind know that it's not in danger. All right, well, those are my my overview of ERP based on 20 years of training and experience. So I hope that you enjoyed that. I would like to take your question and answers now. Let me see, I have a question. Oh, will the PowerPoints be available for printing? Yes, I did send those to the administrator, and so they can forward those on to you with no problem, okay? And, oh, here's a question. What does precious panic attack mean? And I didn't know I put the word precious panic attack in my slide, so if I did, it's a typo, and it doesn't mean anything. A panic attack is a panic attack, which is the catastrophic interpretation of the normal body signs of anxiety. And people drive up their anxiety to panic levels when they have decided that it's dangerous. What's the youngest age for ERP? Excellent question. There is no age that is too young for ERP, because of course, anytime we are requiring what is developmentally expected of a child, we're doing exposure, right? Anytime we're teaching a child to ride a bike when they're 4 or younger, they are saying, I could get hurt, Mommy. What if I skin my knee? What if I fall? Well, it could happen, but we're going to learn to ride a bike anyway, because everyone wants to learn to ride a bike, right? And so we're going to repeatedly expose them, even though, of course, they're in danger. Of course, they could get hurt, but we're going to do it anyway, because everyone needs to ride a bike, or everyone needs to learn how to swim, or whatever it is. So there is no age that's too young for ERP. It sounds like a lot of systematic desensitization. Yes, it is. It does have that learning theory component, of course. We are habituating to things that make to higher and higher levels of anxiety. And so, yes, that is exactly the process by which we're doing it. Yeah. All right. So let's see if there's any other questions. I see that 9 of them have popped up. I don't know. I think I got to all of them. Oh, no. Let's see. Can you talk about ERP with someone with histrionic traits? Oh, yes. So anytime you become an anxiety expert, anyone who becomes an anxiety expert is going to deal a lot with what we call health anxiety and vague symptoms, vague complaints, okay? And those are almost always going to be treated with imaginal exposures, okay? So you're gonna do those scripts, that script writing about this person's most terrible fears, about what's gonna happen, what are gonna be the results of their, the feared outcomes of their behaviors. And in terms of histrionic traits, you're also gonna run into those people who are exaggerating their symptoms, or who are getting secondary gain from their symptoms, and that is not treated with ERP. That has different treatment. But if it's someone who's has a lot of vague symptoms and is got a lot of health anxiety, then you are going to treat that with imaginal exposures and with decreasing checking compulsions, right? We're not going to check the body for signs of illness. We're not going to go to doctors. We're not, right? I had a woman I treated who had 15 mammograms before she came to see me, and she was not allowed to go to the doctor to have any more mammograms. She had to say, maybe I have cancer, maybe not. I'm going to live as if I'm throwing all caution to the wind and neglecting my health. I'm going to go for I'm going to have a once a month, I'm going to do once a month breast self-exam, and going to go to the doctor once a year for my mammogram, or whatever the standard of practice is. And I am going to live in between without checking. I'm not going to read anything on the internet and seek reassurance about cancer or the body signs of cancer. And I'm going to see how it turns out. And this is extremely difficult for someone who has had, health anxiety for many years, all right? What are some of the criticisms of this approach, and how can I respond to the criticisms? For example, I recently heard a therapist call this a barbaric approach. Oh, wow, that's a good point, yes. So I think that, some therapists are like our patients. They want us to make them feel better and lower their anxiety before they go do a thing, right? And it never works like that. We can talk to someone for months or years, like they've done with their 10 previous therapists. But until they do exposures, we've had no treatment, okay? Until there has been a change in the person's behavior and in their symptoms, we've done no treatment, okay? And so, for example, when I fell off my horse the other day, cantering over a jump and ate a dirt sandwich, my trainer did not say to me, now let's calm you down and see if we can do some breathing, and let's really talk about this before you get back on that horse. Okay, she said, get back on. Nope, we can't wait too long. We need to correct this behavior in your horse. He stopped at the jump. We need to correct this behavior in your horse. So I got right back on. And did she make me go over that jump one time? Even though I said, I think this jump is a little high for me. I don't think it's just the horse. I think maybe it's just too much for me. Go over it. I went over it. Did she make me go over it twice? Yes. Did she make me go over it 10 times? Yes. Every time, what happened to my anxiety, right? I said, my anxiety was up here. I was like, I can't do this. This is too much for me. Each time my anxiety got lower and lower and lower from repeated exposure, okay? And so if you want to call that barbaric, I don't know. But we go at the pace that the person can tolerate, okay? My coach has known me for a long time. That's why she knew I could handle that jump. She trained me to jump from the beginning, right? She knew I could handle that. We are doing exposures in a graduated and repeated manner, and we're not going faster than what the patient can handle. We're going faster than what they think they can handle and what they're willing to do, okay? But we're not going to wait till they're ready, because anxiety is never ready, right? The monster tells them that every day. Wait till you're ready. I'll just calm down and then I'll do it, okay? And that never happens. So of course it's not barbaric. That's why it's the #1 approach, okay? That's why it's the #1 treatment. How do you address the moral issues that are causing deep anxiety? Perhaps also for parents who are concerned about things like obsessions regarding pornography, etc. I think this is a good one to end with. The last patient that came to me where their parents were concerned was a 12-year-old boy who was scared that he might be gay. And the mom brought him in and said, my son's depressed. He thinks he might be gay. Our whole family's gay positive. We don't think he's probably gay, but we're fine if he's gay, but please help him, okay? And of course, I talked to the kid, and he said he's had severe anxiety, including separation anxiety and concern about illness since the time he was little, his mom told me. And then he said, I was in class, in the health class, they talked about homosexuality. I got stuck on this thought that I might be gay. And so I've been doing research on the internet, asking myself what makes people gay. I've been monitoring my level of arousal when I'm standing or sitting next to my friends. And of course, now I'm thinking about quitting the football team because you can't play football if you're gay. And I said, well, of course you could, but anyway, I'm sure there are thousands of gay men playing football. And I said, but that's not your problem. The problem is you're trying to get 100% certainty as to whether or not you're gay, and no one can have that, right? And so I'm going to teach you something called exposure with response prevention for your obsessive compulsive disorder that's going to help you stop being a slave to your anxiety, right? So I had to teach this 12-year-old boy, and always in the presence of his mother, about how to embrace thoughts that he may or may not be gay. And we had a whole exposure hierarchy. And we didn't need to look at gay pornography or something in the exposure hierarchy. We created a hierarchy from, writing down I'm gay, carrying around a little card that says I might be gay, looking at boys and saying, maybe I'm gay, maybe I'm not, playing football and saying, who knows what this means about whether or not I'm gay, all kinds of other things, reading books about gay families, looking at pictures of men kissing, and all the while saying, I'm never going to have an answer as to whether or not I'm gay, because sexuality is on a continuum and no one can have a 100% certain answer about anything, and not about this either, okay? So maybe my whole life is a sham, living as a straight person that I've always been, but I'm gonna go on living that way and see how my life turns out, okay? Even though I will never know for sure if I'm gay or not, okay? So it's not about sexuality, it's about OCD, okay? So when you're explaining to parents about these things and your treatment approach, you're always educating the parent constantly and the patient constantly. And there are, for another time, another webinar, there are all kinds of tricky things, and you can always email me. My email is Andrea K, last initial K, at laventanatreatment.com, and ask me a question about your patient. Or if you want to get more education about these things, in addition to reading Jonathan Abramowitz's Bible on exposure therapy, you can go to what's called a BTTI training, the Behavior Therapy Training Institute, which is conducted by the International Obsessive Compulsive Disorders Foundation, and learn how to treat the entire anxiety spectrum. Because once you learn how to treat the worst anxiety disorder, which is OCD, then you'll know how to treat the entire spectrum and transform your practice, okay? That's what I'm trying to do by giving this webinar. I'm trying to brainwash as many people before I die in the #1 treatment for anxiety, since it's the thing that we treat the most. So then you can go on and do the same and brainwash all the other therapists, because of course this is what we're missing in our graduate schools today, is not just CBT in general, but a lot of people miss out on the type of CBT that is most beneficial, okay? And I also see some questions on here about hair pulling. Of course, there are all kind of education about OCD and related disorders like hair pulling, skin picking, and other body-focused repetitive behaviors on the International OCD Foundation website. You can also read Fred Penzel's book, The World Expert on Hair Pulling, called The Hair Pulling Problem. And so that's another great one to use. But I gotta quit, and so I'm gonna let you guys go. And thank you so much for being here. Please stay tuned for the 3 questions in the poll after this talk. And it was just such a pleasure presenting this to you all today. Take care.